Hi, this is Debbie Lee. I'm the WVCTSI Clinical Trials Center of Excellence Training Coordinator, and today we're going to talk about the informed consent process. So let's first talk about the information for the study subjects. What do study subjects need to understand? One of the things is that they may not benefit from the clinical trial. The benefit may be for future patients, so making sure that they understand that. They may be exposed to unknown risk. After entering the study may vary different from their standard of medical practices. So for example, if you're looking at a disease state of diabetes, the patient currently only gets their A1C every 6 months since it's controlled. But with the clinical trial, they will be getting it every 3 months. So making sure that they understand that, because that's different from what their current standard medical practice is for them. You want to make sure that they are making an informed decision. So making sure they understand what will be done to him or her, how the protocol or plan of research works, what risk or discomforts he or she may experience. So for example, that patient that was getting their blood drawn twice a year is now getting it every 3 months. So that's a big change for a patient. And you may think, well, they're already getting their blood drawn. What's a couple extra blood draws? But that patient may be afraid of needles. So it's very important for them to understand that discomfort that they may experience. Participation is definitely a voluntary decision on their part, so making sure that they understand that. So the informed consent process, and I definitely talk about it as a process and not just handing the patient a piece of paper. So let's first talk about when it's appropriate to obtain consent. You must obtain consent prior to screening, prior to any study-specific procedures, prior to any surveys being done. So that informed consent must be done prior to those. So how do you review the informed consent? We have an acronym there as ICF. So that PI or person designated by the investigator, and once again, that does have to be designated on the delegation of duties log. Might be a sub-investigator, that might be a research nurse, study coordinator, so making sure that they are delegated on the delegation of duties log. Ensuring that you have the latest approved version that's being used. So you don't want to print a whole bunch of extra copies because maybe you printed 35 copies, and they're stationed at different areas throughout the hospital. Well, now the ICF has been amended. There's now a version 2, right? So trying to grab all those extra copies back might be an issue. We really suggest using Encore, and it's a management system where the ICF is actually placed into Encore. It's actually in order, so you have the most approved ICF right at the top for you. Very easy to print when the patient's coming in. The PI or person designated should not sign or date the ICF until after the subject or their legally authorized representative signs and dates. So you don't want to, as the person performing or talking to the person about the informed consent, you don't want to sign and date and then hand it to this subject or their legally authorized representative. You don't want to put in the date for them as well. So if they sign and date, they actually need to sign and date the informed consent. Let's talk about electronic informed consent, because that's a big thing, big discussion going on right now with where we're at in the world. In certain cases, an electronic informed consent process may be used to supplement or replace that paper-based informed consent, but it still needs to meet regulatory and institutional requirements. So you can't just say, oh, I already have my informed consent approved. I can, place this in a database, make it electronic, and then start, having that be sent to the patient to electronically sign. It does have to be, and that's my last item here, there must be a clear description of the electronic media, the confidentiality protections, the timing of the consent process should all be included in your IRB submission. So making sure that's all included, and that does have to be IRB approved. Just want to jump back to this one topic here. Make sure you still need to provide that patient with the contact information for the study staff. It's electronic, so how are you going to make sure that they are still getting that information? They might need that. They might get an adverse reaction. They need to contact someone, things like that. So making sure they still have that. So just like the paper, the electronic informed consent is under those same regulations. Let's talk about the ICF process. It really is a conversation. It's not just that piece of paper for them to sign. So here I have my two people talking here. So they are conversing about the informed consent process. You want to provide sufficient time and opportunity for them to consider to participate or not. So allow them to talk to their family, their friends, their colleagues, other healthcare providers. You might be seeing the patient as a specialist, and they might want to take that back to their healthcare provider that they've seen for the last 20 years, making sure they talk to them about it. So making sure you allow that opportunity for them to do that. Because our goal is we want to minimize that coercion or any undue influence to participate. You want to give them opportunity for consideration. Make sure you have copies of the consent. I just talked about not having too many copies, but you want to make sure you have copies of that consent without signature and dates to send home with the patient, right? They can go home, they can mark it up, they have questions. You're talking about taking my blood work every 3 months. Am I going to see those actual results? Things like that. They might have some questions. And allowing them to do that and come back with those questions. Because what we don't want to happen is we want to make sure that we still follow, that Nuremberg code of the voluntary consent of the human subject is absolutely essential, because we don't want to repeat history, right? And making sure the patient understands that they can leave the study at any time without affecting standard of care. Once again, that's why it's very important, if you're doing electronic consent, that patient does have that information and contact you or members of your staff. If the research subject or LAR has no questions after review, that does not necessarily represent that they understand what's going on. Sometimes you've been talking to someone and you can literally see them kind of shut down or their eyes glaze over. So what you want to do is actually kind of do an assessment of their comprehension. Tell me in your own words, what's the study about? What will happen to you? What do you think you'll gain from participating? What are some maybe adverse events or risk, putting it in their language, that may happen to you? So making sure that they really comprehend what's going on with the study. And I just put a couple of questions here, but you can see they're all open-ended questions. You don't want to ask them questions that just they have to say yes or no to. So really making sure that they understand the study. After the ICF is signed and dated and completed, the best practice is to provide a copy to the research subject or LAR. I just want to point out here that GCP, ICH, and the FDA, per their guidance, they both have in their guidance states it should or shall receive a copy. So that's completely up to your research staff. Really want to make sure that open communication is throughout your clinical trial. You want to make sure that you're there to answer any questions, your staff's there to answer any questions. When they're coming in for visits, you're kind of talking to them. Let's say, you're doing an investigational product and they come in and they have more pills than they should have. Asking some questions around that. Maybe the patient thought they understood that they were supposed to take 2 pills a day, but really they're supposed to take 3 pills a day. So once again, just having that open conversation. And once again, making sure, if there's an emergency that they're reaching out, they know who to reach out to. Once again, just having that open communication. Ongoing informed consent, because things happen, right? New information comes available. There's a new risk related to the study. There's a change in study procedures. Maybe, initially you thought you would do three, let's go back to my diabetes patient, 3 A1Cs over the next year, and you decided that you need to obtain one more 3 months after the study. So once again, making sure that patient is aware of that. The length of the study time has, increased. That must be added to the informed consent. And at that time, that patient would need to re-sign that informed consent because they're re-signing, saying that, yes, I understand this new information, I understand there's a change to the procedure, and I'm still willing to participate in this study. So making sure that you are re-consenting them with that modified ICF. Here's an actual copy of an actual warning letter from the FDA. You can see here that they actually failed to obtain, and they have here the legally authorized representative signature and date on the ICF. And you can see here in Part A, they actually randomized the patient before there was any informed consent signed. So once again, talking about going back to making sure that informed consent is signed first, because here's an actual FDA warning letter about that. So let's talk about quality principles. Specifically for the informed consent process and eligibility, you want to verify the following. Once again, you have the correct version of the informed consent. It's the latest IRB approved one at the date and time of consent. The consent process is documented. So somewhere in your documentation, if you're using Epic, you're documenting that, yes, I completed the informed consent process with this patient. Consent and eligibility assessment was performed by appropriate, authorized, and delegated and trained personnel. So for example, the consent was completed. It then, went through an eligibility assessment. I have no medical background, but I'm looking through, the patient's file, and I'm looking at their values on the EKG. I have no medical background. I'm not trained to do that. So making sure that you have the appropriate staff to do that. And once again, re-consenting. They would look at that for a quality principle as well. That informed consent was updated because there was a new known risk. Were subjects re-consented? Each individual protocol, so making sure they're looking at the inclusion criteria is valid. Each exclusion criteria does not apply, and that's verified through source documents. So I know for WVCTSI staff, we actually have an actual checklist that's actually went through and checked off that, yes, they meet the inclusion, and no, all the exclusion is once again, the yes or no check there as well. And we actually have 2 people looking at that, so making sure it's verified by source documents. The timing, right? The consent A was prior to study procedures and eligibility assessment. Documents are complete according to regulation protocols, procedures, policies, consent signatures, and we're going around the ALCOIC principles. So let's talk about what the ALCOIC, and they actually added a C at the end. So what are good documentation principles? It's attributable, so it's the first letter of the acronym. It identifies who recorded the data and when. So if you're in Epic, if you're in any type of electronic data capture system, RedCap, anything like that, it's automatically going to capture that for you because everything's electronic. It pulls your username from when you logged in. It's date stamps it electronically for you in the system. But let's say it's a physical case report form that you have to fill out. There should be somewhere on there for you to sign a date to show that you're the person that actually recorded the data and when it was recorded. Everything should be legible, right? I should be able to pick up that piece of paper and be able to read everything that's on it. It should be contemporaneous. It was recorded in real time. So it all means possible, try to record it in that real time. I get that life happens. I get that things come up, emergencies happen, but you know, try at the very best to always record it in real time. If you can't, at least document that it was done yesterday or whatever. You know, this conversation with this patient actually happened on, you know, 8/17, things like that. So making sure that you're reporting that. It should be original. First record, no transcriptions. So if you have a case report form that you actually have to, if it's a piece of paper that you have to fill out, if you're going to meet with that patient or that, subject, you should actually have that case report form filled out. Take it in with you. You know, you're gathering the weight for the patient, their blood pressure, you know, filling that form out. You should not be taking in a Post-it note to capture that information. So really having either a piece of paper, having your laptop in front of you, if it needs to be electronic, so making sure. The information should be accurate, right? The data should represent observations and facts. You know, it's sometimes hard. We want to put our opinion in there or things that we, the body language of the patient, you know, making sure that we really represent observations and facts. It should be complete. Entries are up to date. They have units. There's no missing fields. You know, if there's an extra field there to capture the point, you know, whatever the pounds, it should be filled out as well. Corrections, because guess what? We're human. Things happen. So we want to correct the error. Totally fine. We're going to initial and date the correction. And sometimes you might need to add a brief statement. So, you know, if you accidentally wrote an 8 and you meant to write a 9, you're just going to write the 9 above it. It really doesn't need a brief statement. But sometimes you might need to add a brief statement to explain why the correction happened. So making sure you think about that when you're making your corrections. Good documentation practices. Let's look at some corrections. So complete documents, right? We talked about that with Alcoic. Complete documents, fully legible, data entered, should be accurate. So I do have a green smiley face there because my first entry is complete, 187.4 pounds. That's good, you know, good to go. Avoid missing fields. Remember we talked about should be complete. So here I have my sad face because I did not write in the point, right? Well, you're like, well, it was 0. Write it in. Or sometimes maybe it doesn't apply, right? Maybe when the patient came in, you attempted to take their weight and unfortunately they were having a really off balance day and they just could not stand on the scale to get their weight. If that's the case, you would need to NA all of those fields to show that you were unable to capture the weight. You would also want to document why, but just, you know, throwing that out as an example. Date and initial all changes that you make. So there I inadvertently wrote a 5, I meant to write a 4. Once again, this doesn't require a statement because I'm just writing the number above it. And once again, making sure it's clear. I'm not going to scribble over that 5. I'm not going to try to write a 4 above it, on top of it, I should say. So making sure everything's clear. So I have a green smiley face there. And I just talked about that. Sorry, don't write over the previous entry. Don't try to make a 3 and 8 because we can tell, right? So my last one there has a red sad face because it's 187.5 and you're like, Debbie, all the fields are filled out. I'm not sure why that's a sad face. But here, I don't know how they're taking the weight. Are they taking it in pounds? And you're like, well, yeah, we're in the US. Well, this is an international study. So maybe they're taking it in kilograms or stones. So you don't know that. So you want to make sure where you're documenting that, the units are there. Just also want to put out if you're actually filling out a case report form, you know, by hand, making sure you're only using a blue or black pen. You don't want to use other colors. You know, when you go to scan that in, they're hard to scan in. So making sure you're using blue or black, and of course, no pencils, because that information can be erased. Can you alter the informed consent after it's been signed? No. Just in case you're wondering, no, no, no. And no, no, no again, right? So you cannot alter the informed consent after it's been signed. So let's take a look at an example of an actual case report form. So I have an example, just a generic example here. Here at the top, I don't have any specific protocol information or anything like that. I've removed all of that. But I just want to look at this. So we have the patient, Debbie Lee, who signed. At the beginning, it looks like she went to write a J for some reason, kind of scribbled through that. So once again, making sure, asking the patient one line through, initial and date. If you did that, once again, same thing. The other thing that could be questionable here is they didn't put the year in. Well, you'd say, well, Dr. Green signed on the 19th. We cannot assume that. So once again, if this patient did put the date in, making sure they're putting in the complete date. The other thing that could be questionable here is that we see that the patient signed in black ink, but Dr. Green signed in blue ink. So an auditor, either internal or external, I might question this, and I've actually sat through an audit where this was questioned. They're now questioning, saying, well, these numbers look exactly the same. They're blue. Did Dr. Green put the date in before the patient or LAR signed? So once again, very important to make sure that you're following those regulations when you're doing the informed consent process. Last thing, I just have sorry, let me get my emoji there. My last thing here is just my resources. I always provide those. Well, thank you for your time.